Guys, today we are going to secure a subclavian central line in a conscious patient. So we'll mark our landmarks after proper cleaning and draping, which will be lateral 1/3 and middle to lateral 1/3 and middle 2/3 of the subclavian bone, clavicle, clavicle, and then we'll puncture at the same site, and then we will sweep beneath the clavicle. We should feel the bone with the needle. We should never ever keep our needle towards the floor. We should face the needle towards the ceiling and towards the suprasternal knot. And the moment we get the blood in the syringe, we will get the guide wire and traverse the vein through the other port of the syringe. The way I am doing it right here, see, the guide wire should go smoothly without any resistance to the guide wire. It should go very smoothly if it is in the vein and not somewhere else. So I will remove the syringe and I'll hold the puncture site with gauze and put some pressure so that the bleeding is stopped to some extent. Then I'll get the dilator to dilate the area as well as the vein so that I can place the central line very smoothly. So I will hold the guide wire with one of my hands, and with the other hand I will put the dilator, and then I will just stretch the skin and then dilate the area as well as the vein. See, the dilator is going smoothly. Sometimes it doesn't, then we'll have to rotate our dilator. So after I dilated the area, I will get the central line, which already I have flushed. I have flushed all the ports of the line, and then I'll put the central line through the guide wire. So see, I'm putting it and it's going smoothly, and I'm looking for the guide wire in one of the ports of the central line. The moment I see the guide wire coming out of the port, I'll open the lock, and then I will again get the guide wire out slowly and gradually till it comes out of that port. Then I'll hold the guide wire with one of my hands, and then I will traverse the central line through the guide wire, but I will hold the guide wire with the hand so that it does not get slipped away. So I will remove the guide wire, and then I will hold the central line, and then I will flush all the ports to make sure that all ports are functional, which I previously had flushed with saline to see if the ports are functional, if there is some manufacturing defect. But there is usually no, it's already checked, but we have to be doubly sure. So I'll flush all the ports. See, there is some some problem. I'm not getting any backflow, so I'll manipulate it. Maybe the wall, it is impinging on the wall. See, I manipulated, I got the blood flow, and I flushed it again with the saline. So I'll flush it. I'll flush the last port now, and the moment I open the lock, I close the lock again so that there is no air entry inside the central line. I don't want air to go inside my central line. So see, I'm flushing all the ports. I got the blood flow and I'm flushing. So clearly all the ports are working, and the line is in the subclavian vein already. Now I'll suture the site. I will suture the line to the patient's skin. But to make patient comfortable, I have to give local, which I already gave before initiating the procedure, so that the patient is comfortable and does not feel any pain at all. Because if the patient is not comfortable and the procedure is painful, so obviously we know the patient will not allow you to touch, and the patient will be in a lot of agony, and you'll be moving, you will be uncomfortable, and it will be unethical. So yeah, we have to give adequate proper local anesthesia. Now I am suturing the patient. See, I'm suturing all ports. All the, there are 2 holes. I'm suturing the line at 3 sides to make sure that the line is not displaced, because we intend to keep the line for a long time. We usually put a central line. There are certain indications for the central line. Number 1, if there is a difficult peripheral cannulation, like you're not able to secure a peripheral venous access in patients like who are obese, who are in shock, who has small veins, who are edematous. So that time Yeah, we put central lines even in patients receiving chemotherapy. Their veins are literally really very small, and it's a challenging thing to secure a peripheral access in such patients. In such cases, we put central line. Also, when patient is on inotropic support, we put central lines. We can give inotropes through a peripheral line. Also, if a patient is receiving total parenteral nutrition, these are all hypertonic solutions. Whatever hypertonic solution we are intending to give to the patient, like mannitol, we have to give through a central line or 3% saline. We never have to give through a peripheral line. So in that case, we'll have to put the central line. And subclavian lines are really very, beautiful lines. They are very easy to operate, very easy to deal with, less chances of infection. The procedure, however, needs a high degree of expertise, because if you're not an expert operator, if you're not expert in this, there are high chances, high likelihood of puncturing the lung, and the patient might land in pneumothorax, which becomes an emergency that time. So you don't want to do that to your patient. So I will recommend that you just do the procedure. You just see the procedures initially, then do under supervision till you gain enough confidence and expertise to do the procedure all alone. So this video is just intended for educational purpose, and it is not intended for somebody who wants to watch the video and do such things in their patients. This is never a good idea. So after suturing all the pores, I will then put tegaderm. I will remove the drape sheet, and before that I will lock all the pores. Again, this is a filter. I am locking all the pores, all the 3 filters I am using. So now I will remove the drape sheet, and I have to do all this gently, and then I will put the tegaderm on the central line. It's a transparent dressing which lets us observe the central line daily. We can see if the line is getting infected, we can get pus through the line, we can get extravasations, there can be leakage. So we can, detect those things well before in time. So that's why the line is tegaderm is transparent, the dressing is transparent. Also, we'll put some paper tape to secure it properly, and then we'll put another tape. And last of all, we'll put one more tape on which we are gonna mention the date of line insertion, which is very important. We always have to mention the date of insertion of the line. That is all for today. I hope you liked the video, and yeah, bye bye till next time.